Okay, good evening, everyone. My name is Ahmed Ghanem. I'm a surgical trainee and the BOMSS trainee representative. Welcome to this evening BOMSS Journal Club. It's the 12th of February 2025, and I'm delighted to have the bariatric team from the Welsh Institute of Metabolic and Bariatric Surgery with us today. As usual, these sessions are recorded, and those who didn't manage to attend can view them on BOMSS official channel on YouTube. May I ask everyone to post your questions and any comments under the Q&A button, and we will answer those questions during the Q&A session. Thank you very much to Johnson & Johnson for sponsoring tonight's session. And now over to you, Mr. Barua. Thank you again for hosting this evening, and if you would like to introduce your first speaker, please.
Thank you, Ahmed, for the invite. Warm welcome from Cardiff. It's quite cold out here. So the first speaker is Marie Lomibau. She is one of the physicians associates on the firm, and she'll be presenting a paper on the ARMS T2D study, long-term follow-up onto the health quality and quality of life aspect. So it's an interesting paper with very good data. So quite interested to hear her thoughts and the discussion.
Hello, good evening. My name is Marie, as Mr. Brewer just introduced. I am a physician associate for Cardiff and Vale, and he's asked me to present this paper titled Health-Related Quality of Life and Health Utility After Metabolic/Bariatric Surgery versus Medical or Lifestyle Intervention in Individuals with Type 2 Diabetes and Obesity, which is the ARMS T2D study. So, as we all know, both type 2 diabetes and obesity is known to have a negative impact on the health-related quality of life and health utilities. Interventions such as traditional medical or lifestyle interventions, which focus on diet, exercise, and medications, are widely used, but their long-term effectiveness is limited. Metabolic or bariatric surgery is offered as an alternative and has shown superior outcomes in weight loss, glycemic control, and overall health. However, there's actual limited long-term data from randomized controlled trials on how health-related quality of care and health utilities change after these interventions. This study aims to compare the 12-year quality of life and health utilities outcomes between metabolic or bariatric surgery and medical or lifestyle interventions. As I said, I've touched upon some of the objectives, and the objectives of this study is to compare long-term between quality of life and health utilities between surgical and non-surgical patients, and to assess whether weight loss and glycemic control improves or correlates with health-related quality of life gains, to evaluate the durability of health-related quality of life changes over 12 years, which is quite a long time, and to provide evidence to guide treatment choices for clinicians and decisions for patients who have type 2 diabetes and obesity. To outline the study and how they've actually gathered the population size. It actually stemmed from 4 parent studies named over here: Stampede, Slim T2D, Triabetes, and Crossroads. The major inclusion criteria for the studies include these 7 over here, which is a type 2 diabetes diagnosis, a BMI between 27 and 45, age between 18 to 65 years old. They must be a GA candidate, and they need to be able to exercise, not pregnant, and no major psychiatric disorder. Out of this, about 355 participants were identified. Unfortunately, 39 withdrew before any interventions. 316 were eligible for the ARMS T2 study, of which 14 were excluded. Out of the 305, there was about 262 patients that were enrolled in the ARMS T2 study. And out of those, about 228 completed the SF36 questionnaire. And that is divided into 152 patients that underwent metabolic or bariatric surgery, and 76 that just had medical or lifestyle interventions. Now, as you can see, in terms of the surgical participants, there were 77 that had Roux-en-Y gastric bypass, 41 who had sleeve gastrectomies, and 34 that had gastric band. This slide just shows a summary of the whole study. So here we've got our population size of 228, which are randomly assigned to have interventions, metabolic and bariatric surgery, and the rest having medical or lifestyle interventions over the span of 12 years. And this box here just shows briefly what the results of the study was. So this slide it's just to show sort of what the primary measures in terms of measuring healthcare and health-related quality of life. So the SF36 questionnaire is widely used and uses 36 questions, which actually cover 8 domains of health, and that includes physical functioning, role physical, bodily pain, general health perceptions and vitality, social functioning, role emotional and mental health. From these 8 components, the physical component score and mental component score are derived from these domains. And for health utilities, the SF6D scores are used, which is actually 11 questions from the SF36, and this creates a score between 0 and 1. I know this table looks a little bit busy, but I'll try and walk you through it. It's trying to show the baseline characteristics for this study, where the mean age for this study was actually about 49.2 years old. The mean BMI is 36.3 kilograms per meter square, and the mean HbA1c is 8.7%. Interestingly, groups matched at baseline, except for a slightly younger age group and a slightly higher HbA1c and a slightly higher triglycerides levels in those patients that underwent metabolic or bariatric surgery. Now that we've had a look at the study's key design and baseline characteristics, these graphs show the key results in terms of the change in physical component score between the 2 participant groups. So here we show the change in physical component score. The circles are the participant groups that underwent MBS, so medical or metabolic or bariatric surgery, and the squares below here show represent the groups that have just gone medical or lifestyle interventions. Interestingly, there's significant improvement in the MBS group, and the benefits were actually most pronounced in the first 3 years post-surgery, with a slight decline over time, but still superior to that of the MLI group. In this graph, it's just trying to show that there's no significant difference between the MBS and MLI group. The mental health and emotional well-being and social functioning remained unchanged over the course of 12 years that the study was done. And it's actually quite interesting because it suggests that weight loss and metabolic improvements do not necessarily translate into mental health benefits, which is interesting. And this final graph over here just shows the changes in health utility over the span of the 12-year study, and it shows that there have been greater long-term improvements in the MBS group, and it showed sort of a significant and sustained improvement, and most of the improvements was also within 3 years post-surgery, followed by a gradual stabilization. The MLI group showed only modest improvements over the first few years, and there's been a decline over time after that. And there's no significant sort of long-term health utility gains that compared to the MBS group. So this study also highlighted the changes in each of the 8 domains recognized in the SF36 questionnaire that I just mentioned. Here, I'm just showing the domains that made the largest difference. So I've only included the 4 domains. First of all, graph A shows a change in physical function. The MBS group had a sharp increase in physical function within the first 3 years, peaking around 3 to 4 years, and showed minor improvements and remained relatively stable throughout the years ahead in the study. Compared to the MLI group. Whereas it also showed that changes in bodily pain, the MBS group actually showed that there has been a little bit more reduced bodily pain, with the largest decrease by year 6/8, I think. Whereas the MLI group also saw some reductions, but actually had a little bit more fluctuations throughout the years. In this graph over here, it shows the changes in vitality between the 2 groups. And the MBS group actually saw higher vitality scores compared to that of the MLI group, where it just starts to go up a little bit and sort of it's just more constant throughout the years. Interestingly, the largest improvement in the MBS group is the change in general health, where the MBS group showed a consistent and sustained improvement in general health over 12 years. And there's it's quite highly significant difference. The rest of the as compared to the MLI group, where it didn't show that much of the change in general health throughout the course of the study. The other 4 sort of components in the SF36, such as the role physical, social function, mental health, and role emotional, showed that there was little to no significant changes over the 12-year study period. So didn't think it was required to be seen on this slide. So what does it actually mean in terms of this study? So it shows that the key trends or the key points to take home from the results is that the largest improvements in health-related quality of care and health utility were observed within the first 3 years post metabolic or bariatric surgery. The physical health benefits remained higher than that of patients who have just gone medical or lifestyle interventions, but declined slightly over time. And that for both participants, mental health and social functioning remained unchanged. With this, the clinical implications meant that it shows that MBS provides a superior and long-term benefits in terms of health-related quality of care and health utilities. This also gives patients and healthcare providers the ability to weigh sort of the benefits or the quality of life benefits versus the potential surgical risks. And that it shows that there might be a little bit of mental health support that needs to be sort of tapped into post-surgery, as this study showed that the MBS group did not improve sort of mental or emotional well-being. So in terms of the strengths of the study, because it's quite a large sort of large sample size and a 12-year follow-up, this actually provided this study insights to the durability of the health-related quality of care and health utilities over longer periods of time, which is good. It included multiple surgical procedures. So there was 3 bariatric procedures that were examined. This enhanced the validity of the findings to different surgical approaches. It also used the validators of health sort of related sort of quality of life and health utility measures such as the SF36 and SF60 scores. And the fact that they had quite a large sample size using the measures that they use with outcomes after sort of metabolic or bariatric surgery. In terms of the limitations of the studies, The SPR 36 only measures generic conditions that does not include diabetes or obesity. So something that would be more specific would probably be more beneficial. Also, the variability in MLI intervention. So the MLI group actually received different combinations of nutrition and counseling and exercise programs and diabetes medication management. This variability limits comparability, which makes it difficult to standardize outcomes in those patients that have just undergone medical or lifestyle changes. The sample size is not large enough to test across different surgeries. Even if it was quite a large sample size in general, it wasn't enough to show within each surgery sort of how the quality of life is affected. And also it's limited to those who met the criteria in the initial recruitment period. So this actually creates a selection bias as participants are pre-selected on specific sort of BMI and health status, which does not necessarily apply to all people with diabetes and obesity. And obviously during the course of this study, things like glucagon-like peptide 1 receptor agonists became widely available for the treatment of diabetes and obesity, but their effects weren't necessarily specifically examined in this study. And that would be quite interesting to see if it actually helps sort of participants that have just undergone medical or lifestyle interventions to see if that's actually changed the sort of like numbers. I think finally, to conclude, just a summary of the study, I think we could say that through this study, metabolic and bariatric surgery shows that it leads to sustained improvements in physical health-related quality of life and health utilities over 12 years compared to medical or lifestyle intervention, and that patients undergoing MBS experience greater benefits in physical functioning, general health and vitality with less bodily pain compared to the group that just had medical lifestyle interventions. Mental health outcomes remained largely unchanged in both groups, which suggests that possible additional psychological support may be needed post-surgery, and that despite potential risks in terms of surgical procedures, the overall benefits of it outweigh its drawbacks for individuals with type 2 diabetes and obesity. Findings of this study actually support metabolic bariatric surgery as an effective long-term intervention, which actually provides valuable insight for patients and healthcare providers making treatment decisions. Thank you very much. I think that's it.
Thank you so much, Mary, for your excellent presentation. You actually answered the questions I have here. I will go through the couple of questions that I received. So what's your comment on, so this study, the cohort has a mean BMI of 36.3 and HbA1c of 8.7% at baseline. Do you think you can apply these findings to individuals with different baselines? To be honest, you almost answered this question at the end of your presentation.
Yes, I think you can apply sort of this study to sort of like different baseline. I mean, obviously it wasn't showed in the study because of the first inclusion criteria, but I do think they could probably apply it.
Okay. And yeah, regarding the mental health, there's lack of significant improvement in mental health outcomes post-surgery. Do you think this highlights the need for comprehensive treatment approach, addressing both physical and psychological aspects of health after bariatric surgery?
Sorry, what was that?
So there's a lack of significant improvement in mental health.
Yeah.
Okay. Do you think we need to, or this addresses that we need a comprehensive approach for the mental health after surgery?
Yeah, I do think that this is probably something that needs to be addressed. In terms of this study, it doesn't show that there was any difference at all after surgery in terms of the mental health of the patients. And this is probably something that sort of it was lacking in. I'm not quite sure on how this would be approached, but it's probably something that needs to be looked at in terms of it's probably something that someone needs to be checking up on them from a psychological point of view and any support that might be available in terms of how patients look at them from the mental health side of things.
Excellent. Thank you. We have another question here. I would like to ask, is there a correlation between weight loss following metabolic and bariatric surgery and the outcomes measured by the SF36 health survey?
Yes, so actually after bariatric surgery, it showed that it had more sort of benefits in terms of weight loss as opposed to medical or lifestyle interventions. And that it actually improved sort of like the physical functioning of patients, and that is where it actually made most of the difference in terms of bariatric surgery. So in terms of the SF36, it's improved the physical functions of the participants that have had weight loss surgery, and it's also improved the vitality of these participants.
Okay, thank you so much. Thank you, Mary. Mr. Baroa, do you want to introduce your second speaker?
Yeah, thank you for that. So the next speaker is David Madison. He is one of our ST3 trainees in the firm at the moment. He's quite keen to develop into upper GI surgery. So this is an excellent opportunity for him to present his slides and forward to an interesting discussion.
Lovely, thank you. Hi, nice to meet you all. I'm Dave. I'm one of the upper GI FT3 registrars in the University of Wales. I'd like to thank the BOMSS for this evening. So before I introduce the paper, I'll talk a little bit about the subject matter behind it and appraise some of the evidence that this one beforehand.
Sorry, Dave, may I interrupt you because we hardly hear you. We can hear when you look to the left. I'm not sure if your mic on your left-hand side.
Can you hear me if I speak this way?
Yeah, if you try again, yeah.
Can you hear me?
Yeah, if you speak up a bit, yeah.
Okay, I'll try and speak as loudly as I can. Sorry if the microphone quality
Yeah, sorry for that. Thank you.
Okay. So, as an introduction, there's been a sort of massive transition to laparoscopic and robotic bariatric surgery in the previous decade or so, and this has introduced procedural challenges along the way. I get one such challenge, which is centered around the paper I'll be discussing today, is intra-abdominal suturing and knot time, and whether barbed sutures, such as Stratafix or V-lock, are preferential when looking at and comparing them against non-barbed sutures. They are suggested to reduce localized tension on approximation lines in surgery. So before I introduce I'll just present evidence. There was a very good meta-analysis done in 2019, which showed that suture time and operative time were both significantly increased in a barbed suture group. It's worth noting that there was no difference in post-operative complications or hospital stay. Furthermore, in 2020, another meta-analysis showed that there was the gastrointestinal anastomoses in question were laparoscopic Roux-en-Y gastric bypasses and single anastomosis gastric bypasses. Again, in this meta-analysis, there was no statistically significant change in complication rates. And these findings are consistent throughout various other meta-analyses and systematic reviews. So pending that, the paper that we're looking at is delivered by the global and was uploaded to obesity surgery and looked at the safety and efficacy of barbed sutures compared to non-barbed sutures in bariatric surgery. And this was an updated systematic review and meta-analysis. So the hypothesis from Attaya and their colleagues sort of compare surgical outcomes in laparoscopic bariatric patients. The variable was used in barbed sutures in the form of stratific or V-lock sutures versus conventional non-barbed sutures. The primary outcomes in this meta-analysis included complication rates, operative time, and inpatient stay length. Critically, they have found no previous papers that have looked at differences in rates of bowel obstruction, a potential complication associated with barbed sutures, and they looked at that as a forward complication rate between the two groups, which is a new finding. So a little bit about the study design. As I've already discussed, it's an updated meta-analysis which adds to previous research with adding a few findings of its own. Following eligibility criteria, it narrowed it down to 20 different studies and narrowed this down further to 11 studies, 4 randomized controlled trials, and 7 observational cohort studies. Of these, they were sort of subcategorized into which operations they centered around. And 7 looked at laparoscopic Roux-en-Y gastric bypasses, 2 at laparoscopic gastric sleeve, and 2 single anastomosis gastric bypasses. 3 of the studies used Stratifix as the barbed suture of choice, and the rest used V-lock. I won't go into too much detail about the eligibility criteria and how they narrowed it down, but you can see how they narrowed everything down on the left-hand side table. Of note, there was almost 27,500 patients included, obviously very much skewed towards the use of sutures in the conventional non-barbed group. Bias was tried to be reduced in the non-randomized studies through the Robin-1 system, and the randomized control trials were classified at low risk of bias using the ROB system. Eligibility was done using retrospective or prospective studies comparing barbed and non-barbed sutures, and then they excluded studies with no control that weren't in English and that didn't use non-bariatric operations as a focus. So looking at their results of mean operative time, they found that there was an 8-minute average reduction between operations using barbed versus non-barbed sutures. However, critically, this is not with regards to the first set of results, operative time showed an 8-minute average reduction between operations using barbed versus non-barbed sutures. However, this was not statistically significant, and there was a high degree of heterogeneity in the data. As such, they used a leave one out analysis to try and address this heterogeneity. However, as you can see, results were unchanged and consistent on that front. And there was no individual paper which could explain that degree of heterogeneity. Following on from that, they used meta-regression using an individual subtype, an influential characteristic in the form of BMI to try and explain why the data was so variable. This meta-regression revealed that mean BMI didn't significantly affect the operative time. So, given the findings that we've just discussed, they subdivided this and grouped it according to surgery. What they found was that laparoscopic Roux-en-Y gastric bypasses showed a significant reduction in operative time with barbed sutures when compared with non-barbed sutures, as you can see from the mean reduction in time of 12 minutes and the statistical significance that comes with that. They found that in the seven studies that looked at laparoscopic Roux-en-Y gastric bypass, that 6 of these had a reduction in time using barbed sutures. Unfortunately, again, like with the operative time in total, there was a high degree of variability and heterogeneity in the data. This couldn't be bypassed with the leave one out analysis, which they conducted on this data as well. However, as you can see, the results consistently show significant reduction in operative time using barb sutures. And the last thing to talk about regarding the subgroups is that subgroup analysis of laparoscopic Roux-en-Y bypass revealed that only observational studies exhibited a significant reduction in operative time, as opposed to the two included randomized control trials which looked at the Roux-en-Y gastric bypasses. The observational study noted a non-significant 14-minute reduction, whereas the observational study noted a significant 14-minute reduction, whereas the RCT noted a non-significant 8.65 reduction to give a mean of 12 minutes. Okay. Right, this was the lead analysis of the and this was looking at the differences between the observational and the randomized control trials. So as you can see, the time differences with the randomized control trials were not statistically significant compared to the observational trial, which are, which is a sort of should be noted. Suturing time was conducted on 5 of the studies included out of the 11, and this was limited due to the outcome data that was provided. They looked more closely at these 5 studies and found that in laparoscopic Roux-en-Y gastric bypasses, the duration of suturing, which only included the gastrojejunal anastomosis in these cases, was reduced. Moving on to the complication rates. Interestingly, and perhaps unsurprisingly, the complication rates, including leak, stenosis, bleeding, and bowel obstruction, which is a new finding, were not statistically significant in difference between barbed and non-barbed groups. They also found that hospital stay was not affected by the use of barbed implant. So the discussion points out as follows. Barbed sutures reduced suturing time compared to non-barbed sutures, although this was more prevalent in the observational study. And they found that reduced operative time in laparoscopic Roux-en-Y bypass surgery could be seen with barbed sutures as opposed to other laparoscopic bariatric surgery, which should be noted is different from the meta-analysis that had been done previously, stating widespread reduced operative time in bariatric surgery. They also showed that complication rate and hospital stay length was similar between the 2 groups. I'll quickly talk about the limitations, which I'm sure some have picked up on. The statistically significant findings were limited to observational studies over the randomized controlled trials. And although they tried desperately to, address the heterogeneity and variability of data using lead-on-out analysis, there is still a degree of variability and a degree of bias when looking at the cohort studies. They also had the limitations of the suture time analysis with regards to laparoscopic Roux-en-Y only encompassing gastrojejunal anastomosis instead of jejunal anastomosis and mesenteric suturing. So this limited outcome availability sort of hinders the results from that front. And I think possibly most importantly is that there was no cost analysis in this barbed suture usage. Doing a quick sort of search regarding costs, it seems that barbed sutures are at least 10 times more expensive than the conventional absorbable non-barbed sutures. And whether in the NHS that can be justified given the findings of these meta-analyses is a discussion point. I'll leave up the sort of poster associated with this study while we have a discussion. Thank you.
Thank you so much for your presentation. We struggled a bit with the mic, but thank you so much for your presentation. I have a couple of questions here for you. So first one, keeping in mind that it only decreased the suturing by 5 minutes and decreased the overall time in Roux-en-Y gastric bypass by 12 minutes, and keeping in mind the heterogeneity between the studies as well. would this paper actually change your practice? I'm not sure what do you do in your practice? Is it do you use Stratifix and VLOOK, or you just use normal stitches?
So our hospital doesn't have a strict bariatric unit, but we do use Stratifix regularly for gastrostomies and for ease and suturing. Like, for example, yesterday we did a wedge resection of a disc using Stratifix to close the gastrostomy, and for technical ease and one person use, it is very helpful. So in terms of our clinical approach, it is something that we use, but I can't speak sort of inside of a bariatric unit.
Okay, thank you. We have another question, which is almost similar. Which is, do you think that's regarding this, the difference is 5 minutes in suturing and 12 minutes in Roux-en-Y gastric bypass? Do you think this would positively impact patient care and increase numbers of procedures, given the structure and limitations of NHS theatre lists?
It's very difficult to say because the suture time and the operative time sort of don't align in this study with regards to the observational studies and the randomized control trials. I think there is certainly potential for decreased suture time and decreased operative time based on previous meta-analyses. And so, given the high number of patients and increasing number of patients who are going to be operated on bariatric list, it's certainly something which we consider going forward. But with the caveat that, cost analysis may not be there.
Thank you. And sorry, you told me now in your hospital you use barbed sutures for what procedure? For anastomosis, or just trying to?
So we use it to suture gastrostomies when we have chest or when we have to get into the stomach. So some of the consultants in the practice do use Stratifix when they're doing gastrojejunostomy, but at the moment it's clinician prerogative as opposed to protocol-based suturing.
Because I think for because the problem with the barbed suture, it's not a problem, it's an advantage, to be honest. But if you're for trainees at the beginning of training, I think they need the sense of suturing and tying, because you need the skill for head hernia repair and suturing the crura and stuff like this. So from one point of view, if you keep suturing and stitching using Vicryl or Ethibond or whatever, you'll keep the skill. Obviously, for a senior surgeon who has been doing this for a long time, wouldn't make a difference. Would be just making the surgery quicker and probably adding maybe add some patients. I don't think, to be honest, this 5 or 10 minutes will change the list. Mr. Barua, do you think it will add to the list?
Yeah, the main reason I included this study was as a discussion point, because the evidence is not conclusive one way or another. So there's a training perspective, there's an NHS perspective, and then there is the private perspective, or for example. So in training, as you said, Ahmed, so through my bariatric fellowship, we had surgeons mostly doing using barb sutures, and then one of the surgeons I trained with would do a fully hand-sewn with normal non-barb sutures. And timing-wise, there's not that much of a difference. But I think training in non-barb sutures actually takes in barb sutures actually is teaching somebody to use them takes a little bit more effort, because obviously there's less scope for error. So your sutures have to be precise. You can't take the suture out, for example. So I would say in experienced hands, it's an advantage. In inexperienced hands, the traditional sutures actually probably is better. So in our unit, we do revisional bariatrics procedure with the tertiary resectional unit as well. We do deal with a lot of the emergencies. So I tend to use barb sutures for all the anastomoses. And that's because you don't always have a reliable assistant who can follow you, for example. So the advantage of the barb sutures, obviously, is you don't have to tie a knot at the beginning. You don't need an assistant to follow, and you don't necessarily need to tie a knot in the middle or at the end either. You just need a little bit of crossover. So that's quicker. And if you don't have an experienced assistant, but if I've got a trainee, I usually give them a non-barb sutures if they're starting out, because it's easier to train somebody, and then once they're a bit more comfortable doing anastomosis, then transition to the barb sutures. For my JED, I actually do a fully stapled intracorporeal. So it's the gastrojejunectomy, or occasionally a duodenojejunectomy is where we would do the hybrid technique.
To be honest, if you do that, if you do the fully stapled technique for the JJ, and you do, for example, a Orville circular stapler for the gastrojejunectomy, so you get away from
We've kind of moved away from using circular staplers, both for the esophageal anastomosis as well as gastrojejunal anastomosis, mainly because there's increased rate. Firstly, you need to be very careful to make sure all the layers are included. Your purse string has to be very, very accurate. And secondly, you have a longer term, you have more risk of anastomotic stricturing. We almost never see anastomotic stricturing in vertical anastomosis, so stapled verticals. So, I don't like circular staplers personally.
Fair enough, yeah. Just some units still do this. Fair enough.
Jejunostomies, particularly, it's still being used. I mean, the problem with, obviously, in bariatric, if you're excising the pouch and doing an esophageal jejunostomy, then it comes into play. But that's a very rare situation. So yeah. I mean, vertical stapled with the enterotomy being closed, barbed is what I would normally do, unless there's a trainee who is not very comfortable with the barbed, and then I'd let them do the traditional suturing. Yeah.
Thank you. So the difference in price. So I know that this paper didn't
almost 10 times.
Didn't conduct. Sorry, didn't.
Almost 10 times difference between one traditional suture and a barb suture in the UK.
The price.
Yeah, the price.
Yes, yeah, exactly. Yeah. So I think it's no brainer. We don't need data to prove this. I think the cost effectiveness. I don't know, to be honest, but it's more expensive, but makes life easier.
Yeah.
But like other stuff, like the robot, for example, there's an arm here, so that we don't have a data yet that the robot is better, for example, for outcome. Yet we use it.
Yes. I mean, it's interesting. I was quite curious to see what people's thoughts were in terms of what they were using in their own units, etc. Because in my mind, certainly, there's no doubt that a fully hand-sewn intracorporeal anastomosis is better off with a traditional suture, because you do the posterior, say a gastrojejunectomy, you do the posterior holding suture, then you do the enterotomies, and do a full leg. I mean, the length of the suture helps, because you can adjust the length much more easy. Well, you can adjust the length. You only got, for example, V-lock 2 different lengths, so 15 and 25. 25 isn't quite long enough for a fully hand-sewn if you want to use a single suture, for example. Yeah. So there are benefits of both. So you have to, tweak it to how you like it. But certainly for training, I think the traditional suture is easier.
Yeah. Okay. Yeah. So thank you so much. That's it for today. Thank you for the excellent presentation. Very interesting topics.
Yeah.
Thank you so much for.
Take care.
Thank you, everyone. And this concludes tonight. Thank you, everyone, and see you in the next Journal Club next month. Thank you.